Welcome to Prism Rounds, where we break down one study at a time.
Or in today's case, two massive studies and a heavy-hitting editorial, all dropping in the same issue of the New England Journal of Medicine.
Yeah, no kidding.
It is a very good week to be a lung cancer nerd.
That's right. It is Wednesday, February 11th, 2026. And if you treat lung cancer, you know that for a long time, the landscape for EGFR-mutated non-small cell lung cancer was, I don't want to say easy, but the flowchart was pretty linear.
It was deceptively simple, right?
Exactly. You found the mutation, you gave the pill, usually osimertinib, and you watched the patient do well for, a pretty good stretch of time.
It was the era of the magic bullet monotherapy. You prescribed it, you high-fived the patient, and you saw them in clinic in 3 months. But as we are seeing today, that era is evolving.
It really is.
The simplicity is gone. We are shifting from which pill do we give to what combination maximizes survival, and maybe more importantly, what do we do when the pill stops working?
Right. And that's a perfect setup for what we're tackling today. We are looking at a double feature. First up, we have the long-awaited overall survival data from FLAURA2. This is the frontline setting, the very first decision you make. Then we're going to pivot to the resistance setting with a new antibody-drug conjugate, or ADC, in a trial called OptiTROP-Lung04.
And tying it all together is an editorial by Dr. Roy Herbst, which really puts this whole shift into a broader historical context. He basically asks, are we finally doing for lung cancer what we did for leukemia and lymphoma decades ago?
Which is a huge question. So let's set the stage. Why do these two papers matter right now, today? Why should you, our listener, care about these specific trials amidst the constant noise of oncology publishing?
Well, look at the clinical context. Osimertinib monotherapy has been the undisputed king of the hill for first-line EGFR mutations since the original FLAURA trial. No question.
It was a game changer.
A total game changer. It beat the first-generation drugs, it hit CNS mets, it's generally well-tolerated, but, and this is the big but, the median progression-free survival has been stuck at around 19 months.
Right. And while 19 months is great compared to where we were with chemotherapy, it's not a cure. The cancer eventually wakes up. It finds a way around the drug.
Always does. So the hypothesis with FLAURA2 was, what if we don't save chemotherapy for later? What if we don't hold it in reserve for second line? What if we hit the cancer with everything we have? Osimertinib plus platinum pemetrexed right out of the gate.
Upfront intensification.
Exactly. It's a concept we're very familiar with in other cancers. We do it in myeloma. We do it in breast cancer. The question is, does it work here? And is the toxicity worth it?
And then for the second paper, OptiTROP-Lung04, the stakes are arguably even higher.
I would say so, yeah. Because once a patient progresses on osimertinib, our options have historically been, well, they've been underwhelming.
It's a tough conversation to have in clinic.
It is. Usually it's just platinum doublet chemotherapy, which works, but not for very long, and with its own toxicity. It's a holding pattern, not a solution.
So OptiTROP is introducing a whole new player, Sacituzumab, Tirumotecan, or SAC-TMT for short.
Right, which is an antibody-drug conjugate. This isn't just another TKI. It's a whole new mechanism of action for this specific population that desperately needs it.
So we are potentially looking at changing the standard of care for both the very beginning of the treatment journey and the later stages, all in one journal issue.
That is the headline. The mechanism-based approach that started way back in the 1970s is finally maturing in lung cancer. We are moving from single agents to strategic, thoughtful combinations.
Okay, let's unpack this. We have to start at the beginning with the frontline setting. Let's do FLAURA2.
This is the study everyone has been waiting for. The PFS data was presented a while ago, but this is the main event.
Right. We already knew that progression-free survival, or PFS, was positive. That was reported previously. We knew that adding chemo delayed progression. But today, we are talking about the gold standard. Overall survival. Did these patients actually live longer?
The ultimate question. So let's quickly reorient ourselves with the design so we know exactly who we're talking about. This is a phase 3 international open-label trial. They enrolled 557 patients.
And these were the classic EGFR population, the ones we see every week.
Yes, exactly. Patients with locally advanced or metastatic non-small cell lung cancer. They had to have one of the classic sensitizing mutations, either an exon 19 deletion or the L858R point mutation.
Okay.
And crucially, they were treatment naive in the advanced setting.
At first diagnosis.
Exactly. No prior systemic treatment for advanced disease. They randomized them 1-to-1. One group got the standard osimertinib monotherapy, 80 milligrams daily. The other group got the combo.
And just to be specific on the chemo, because the details really matter here, what was the exact regimen?
It was pemetrexed plus a platinum agent, so the physician could choose either cisplatin or carboplatin. They did this for 4 cycles, which is the standard induction period.
Right.
But then, and this is a key point, they continued with maintenance therapy. And maintenance wasn't just osimertinib, it was maintenance osimertinib and maintenance pemetrexed.
So they didn't just drop the chemo after 4 cycles, they kept the pemetrex part of the doublet going.
They did, until disease progression or unacceptable toxicity. And the randomization was well stratified, as you'd expect, by race Asian versus non-Asian WHO performance status, 0 or 1, and the mutation testing method used.
Okay, so the primary endpoint was PFS, which they already hit. We knew that was positive. But the focus of this paper in the NEJM is the key secondary endpoint, overall survival. And I have to ask, why does this matter so much? If PFS is great, if you're keeping the cancer at bay for longer, isn't that enough sometimes?
It's a great question, and it's particularly important in EGFR lung cancer. These patients often live for years, they get multiple lines of therapy.
Right, there's a lot of crossover.
There is. And sometimes a treatment extends the time to the first progression, but it doesn't actually help them live longer overall because the cancer becomes more resistant or harder to treat later. Or the subsequent therapies that the control arm gets are so effective that they dilute any early benefit.
It all washes out in the end.
Exactly.
Yeah.
Proving an overall survival benefit in a first-line EGFR trial is incredibly difficult for that very reason. It's the holy grail.
So did they find it?
They did,
Yeah.
and it's a pretty clear signal. Let's look at the absolute numbers first, because I think that's what's most tangible for patients.
Agreed.
The median overall survival in the osimertinib monotherapy group, the current standard of care, was 37.6 months. That's just over 3 years.
Which is pretty consistent with what we saw in the original FLAURA2 trial. It's a believable control arm.
Completely. It confirms that baseline. So 37, almost 38 months is the bar to beat. Now, looking at the combo group osimertinib plus chemo, the median overall survival was 47.5 months.
47.5 months. Let that sink in. That is nearly 4 years.
It is. That is a 9.9-month improvement in median survival.
Nearly 10 months. That is almost a year of extra life on average.
Right.
We are not talking about a statistical wobble of a few weeks here. This is clinically massive.
It is statistically significant and, I think everyone would agree, clinically meaningful. Let's look at the relative stats now. The hazard ratio for death was 0.77.
Okay.
The 95% confidence interval was 0.61 to 0.96. And crucially, that does not cross 1. The p-value was 0.02.
So a 23% reduction in the risk of death over the entire course of the study.
Precisely. And if we look at the Kaplan-Meier curves, they're really telling. They start separating around maybe 16 months or so, and that gap just widens and stays wide.
What about landmarks, like at 2 or 3 years out?
Great question. At 36 months, so 3 years out, 63% of the patients in the combo group were still alive, compared to only 51% in the monotherapy group. That's a 12-point difference.
That is compelling. But I noticed in the paper they broke this down by subgroups, which is always where the interesting debates happen. We always hear that L858R mutations are the bad actors compared to exon 19 deletions. They don't do as well. Did the chemo help them specifically?
That's a fascinating part of the data and something people were really watching for. And you're right, historically, L858R mutations do have worse outcomes with TKI monotherapy. They just don't respond as deeply or for as long.
So what happened here?
In this trial, the L858R subgroup did show a clear benefit from the combination. The hazard ratio for death in that group was 0.76. For the exon 19 deletion patients, the hazard ratio was also 0.76.
Wow. So it was an identical relative benefit. The chemo seems to be acting as an equalizer. It's lifting all boats, including ones that were sitting lower in the water.
That is a perfect way to put it. It seems to erase that biological disadvantage, or at least blunt it significantly.
What about brain mets? That's another high-risk feature that we worry about constantly.
Also a consistent benefit. For patients who had CNS metastases at baseline, the hazard ratio was 0.72. For those without, it was 0.77.
So again, very consistent. A little bit more benefit even for the brain met patients.
It seems so, yes. The confidence intervals are a bit wider for the CNS group just because of the smaller sample size, as you'd expect, but the point estimate is strong. It seems adding that systemic chemotherapy provides a level of disease control that benefits these high-risk groups, perhaps disproportionately.
Okay, this all sounds incredible. A 10-month survival benefit is something we dream about, but we have to talk about the cost of doing business here. And I don't mean dollars, I mean toxicity.
Right.
You're asking a newly diagnosed, likely terrified patient to not just take a pill, but also to come in for IV chemo to deal with all that entails.
And that is the absolute crux of the debate around this study. This is what we'll all be discussing in tumor boards. The safety profile shifts drastically when you add chemotherapy.
So how bad is it?
In the combo group, the rate of grade 3 or higher adverse events was 70%. 70.
70%. That's a lot. More than 2/3 of patients had a severe side effect.
It is. Compare that to 34% in the monotherapy group. You are more than doubling the rate of severe toxicity.
And what are we seeing? Is it weird, unexpected stuff, or is it the typical chemo side effects?
It's what you'd predict. The driver of this toxicity is primarily myelosuppression. So we're talking about anemia, neutropenia, thrombocytopenia, nausea, fatigue. This is the classic signature of platinum pemetrexed.
Right, so it's not a mystery toxicity, but it's real for the patient. It means fatigue, a higher risk of infection, potential for bleeding, more trips to the clinic.
All of the above. And it led to patients stopping treatment. Adverse events led to the discontinuation of the osimertinib component in 12% of the combo group versus only 7% in the monotherapy group.
Okay, so a bit higher.
A bit higher. But here's a really interesting number. The discontinuation of the Pemetrex component due to AEs happened in 50% of patients.
Wow, so half the patients couldn't stay on the maintenance chemo indefinitely. They had to drop it because of side effects.
Right. Which tells you that while the combo is effective, that maintenance Pemetrex is not a free lunch. It has a cumulative toxicity burden.
So the toxicity is really front-loaded during those first 4 cycles with the platinum.
That's where it's highest, for sure. Once they get through induction and switch to maintenance, the rates do drop. But still, it is a significant increase in the medicalization of their life. More visits, more blood draws, there's more supportive care medications. It's a much bigger ask.
So summarizing FLAURA2, we have a clear, statistically significant and clinically meaningful survival benefit. A 10-month gain in median survival. It works across high-risk subgroups, but it comes with a very heavy toxicity price tag.
That is the trade-off.
Yeah.
Perfectly stated. Strength number 1 is that significant OS benefit. As I said, showing OS benefit in first-line EGFR is incredibly hard. The fact that they showed it here and with this magnitude is a major win for the trial and for patients.
And strength number 2.
I would say the consistency, the fact that it works so well for CNS Mets and for L858R really strengthens the finding. It's a robust result. It's not being driven by one small, favorable subgroup.
But the limitations. We've touched on them, but let's be explicit.
Limitation number 1 is the open label design. Now, for an endpoint like death, investigator bias is less of an issue. Death is a pretty objective endpoint.
Hard to argue with that one.
Right, but it can influence reporting of other things like quality of life or progression.
Right.
But the big one, limitation number 2, is clearly that toxicity burden. Is a 10-month median survival gain worth the side effects for everyone? The paper can't answer that. That's a conversation.
And that brings us to applicability. Who is this for on Monday morning?
This applies to fit patients. The study required a WHO performance status of 0 or 1. If you have a frail 85-year-old patient with multiple comorbidities who can barely get out of bed, you are probably not going to blast them with platinum doublet chemo just to chase the FLAURA2 benefit.
No, you're going to stick with the monotherapy, which is still a fantastic drug.
Exactly. This is for your younger, fitter patient who is willing and able to tolerate the upfront intensification for that long-term gain.
Okay, so that's the front line. We now have a new, more aggressive, more effective option. But let's say we treat a patient maybe with monotherapy, maybe with the combo, and eventually, inevitably, they progress.
Right. The cancer outsmarts the treatment, and this is where the clinical need is it's desperate. The biology of the tumor changes, it evolves, new resistance mechanisms pop up.
Enter Optotrop lung of 4.
This is the second paper, and it's looking at exactly that scenario.
Right.
The post-EGFR TKI resistance setting.
So set the scene here. Who are these patients in this trial?
These are patients with EGFR-Mutated advanced NSCLC who have progressed after receiving EGFR TKI therapy. And importantly, the vast majority, about 95% of them, had received a prior third-generation TKI.
So for all intents and purposes, they progressed on osimertinib.
Yes. This is the exact population we see in clinic, the post-OC patient. This is the central challenge in EGFR lung cancer today.
And what were the arms of the trial?
They randomized them to receive either the experimental drug, Sacituzumab, Tirumotecan, let's just call it SAC-TMT, or standard of care chemotherapy.
And the standard of care here, you mentioned this earlier, but it's an important point. It was pemetrexed plus platinum, not docetaxel.
That is a crucial detail and a real strength of the trial design. Many second-line trials in lung cancer use docetaxel as the comparator, which is, frankly, a low bar to clear.
It's a tough drug with modest efficacy.
Right. But here, the control arm was platinum pemetrexed, which is what most of us would actually use for a fit patient who progressed on OC alone. So they are comparing against the real-world standard.
Okay, so what is this new drug, sac-TMT? We know the name Sacituzumab from breast cancer, but that's usually linked to Tirumotecan. What is Tirumotecan?
So it's a TROP2 directed antibody drug conjugate. The antibody part, the sacituzumab, targets TROP2. TROP2 is a cell surface antigen that is highly expressed in many solid tumors, including EGFR-mutated lung cancer.
So it's the homing device?
Exactly. And it's linked to a cytotoxic payload. In this case, the payload is a belotecan-derived topoisomerase I inhibitor called Tirumotecan. So it's a different payload than what's used in breast cancer.
So it's a smart bomb. It finds the TROP2 on the cancer cell, gets taken inside, and then delivers the chemo payload directly to the tumor, hopefully sparing normal cells.
That's the concept.
Yeah.
And this trial was a phase 3 randomized open-label study conducted at 66 sites, all in China.
We'll come back to that point. First, let's talk endpoints.
The primary endpoint was progression-free survival, as assessed by a blinded independent review committee. So even though the study was open-label, the primary endpoint was read by people who didn't know which arm the patient was on.
Good. That mitigates some of the bias.
And the key secondary.
The key secondary endpoint was overall survival, and it was tested hierarchically after PFS.
We'll definitely come back to that hierarchical part in our teaching segment, but for now, let's hear the results. Did the smart bomb work? It worked incredibly well. Let's start with the primary endpoint, PFS. The median PFS for patients receiving sac-TMT was 8.3 months. For the chemotherapy group, it was 4.3 months.
So it nearly doubled the time to progression.
It did. A 4-month improvement. The hazard ratio was 0.49.
0.49. Let me just repeat that. That is a 51% reduction in the risk of progression or death.
It is.
A hazard ratio like that is rare to see in any cancer, let alone in a resistant lung cancer population. We usually get excited about a hazard ratio of 0.7 or 0.8. This is in a different league.
It really is a massive signal. And what's even more impressive is that this translated directly into an overall survival benefit. This was an interim analysis for OS, but the signal was so strong it crossed the pre-specified statistical boundary for significance.
So give us the numbers.
The median OS for the chemotherapy group was 17.4 months. For the sac-TMT group, the median OS was not yet estimable.
Which is always a good sign.
It's the best sign. It means that at the time of the analysis, more than half the patients in that arm were still alive. But even so, the lower end of the confidence interval for the median was already at 21.5 months, so we know it's going to be substantially better.
And the hazard ratio for OS?
The hazard ratio for death was 0.60. The 95% confidence interval was 0.44 to 0.82. The p-value was 0.001.
So a 40% reduction in the risk of death compared to the best available chemotherapy.
Correct. And if you look at the 18-month survival rate, another tangible number, 65.8% of patients on sac-TMT were alive versus only 48.0% on chemo.
Okay, those are absolutely practice-changing numbers. But again, we have to look at the toxicity. ADCs are often called smart chemo, but I always tell my fellows smart chemo is still chemo. It still has side effects.
Absolutely. And this is where the story gets interesting. The overall rate of grade 3 or higher adverse events was actually quite similar between the two groups. It was 58% for sac-TMT versus 53.8% for the chemo arm.
So the amount of severe toxicity is basically the same, but I'm guessing the type of toxicity is very different.
Very different. With standard platinum pemetrexed, we worry most about the blood counts. In this trial, the hematologic toxicity, so anemia, neutropenia, thrombocytopenia, was actually lower with sac-TMT than with the platinum chemo.
That's good. That means less need for transfusions, less GCSF, less risk of febrile neutropenia.
Right, but there is a very specific ADC-related toxicity you have to watch for, and that is stomatitis.
Mouth sores.
Exactly. Any grade rate of stomatitis was reported in 64.4% of patients in the sac-TMT group, compared to only 4.9% in the chemo group.
Ouch, that is almost 2/3 of patients dealing with some level of mouth sores. That can be miserable.
It can be. Now, to be fair, the vast majority of it was low grade, grade 1 or 2. Severe grade 3 stomatitis was only seen in 4.8% of patients, so it's manageable with good supportive care, but it definitely affects quality of life. Eating, talking, these things matter a great deal to patients.
What about lung toxicity? With ADCs and lung cancer, we always worry about interstitial lung disease, or ILD.
That is the surprising and very positive finding here. In this study, there were 0 reported cases of drug-related interstitial lung disease in the sac-TMT group.
0? That's amazing.
0 reported. Now, We always have to stay vigilant as this drug moves into broader populations and maybe less fit patients. But for a phase 3 trial, that is a very, very reassuring safety signal compared to some other ADCs in the lung cancer space.
Okay, so let's wrap up optotropy, strengths and limitations.
The biggest strength is obvious. It convincingly beats the standard of care, platinum pemetrexed, on both PFS and OS. And it did so with a manageable, albeit different, toxicity profile.
And it worked in the exact population we need help with.
Yes. It was effective regardless of T790M status and after failure of a third-generation TKI. That's a huge strength.
Limitations.
The big one, as we mentioned, is geography. The trial was conducted exclusively in China. The population was 100% Asian.
And why does that matter for applicability in, say, North America or Europe?
Well, we know EGFR epidemiology, and even some aspects of tumor biology can differ between Asian and Western populations. More importantly, pharmacokinetics and drug metabolism can differ. So regulatory bodies like the FDA or EMA will almost certainly require bridging data or a confirmatory trial that includes a significant number of Western patients to ensure the safety and efficacy profile translates.
Right. We've seen drugs get approved in one region and held up in another for that exact reason.
Exactly. So for applicability, this is a potent, exciting new option for the post-osimertinib setting. It will likely become the new standard of care, but we need that Western or global confirmatory data to fully unlock it worldwide.
So we have these two massive studies. FLAURA2 says use chemo early for more benefit but more toxicity. Optotrop says use this new ADC late for a big benefit over old chemo. It's a lot to process.
And to help us synthesize all of this, we have the editorial by Dr. Roy Herbst.
The voice of reason? What's his take on all this?
He starts with a really nice historical callback. He references the work of Vincent DeVita back in the 1970s with Hodgkin's disease.
The famous MOPP chemotherapy regimen.
Right. DeVita and his colleagues prove that combinations cure cancer, not single agents. Dr. Herbst argues that this mechanism-based combination approach is finally being realized in EGFR-mutated lung cancer. We aren't just throwing drugs at the wall. We are strategically targeting pathways and resistance mechanisms.
So how does he interpret FLAURA2 specifically?
He gives it its due. He acknowledges that achieving a median survival of nearly 4 years establishes a new standard of care. You just can't argue with a number that high. But he immediately poses the critical question, is the toxicity worth it for every single patient?
Is it additive or synergistic question? Are we just getting the benefit of two drugs given at once, or is something more happening?
Precisely. He asks if we were just buying time or if we're actually changing the biology of the tumor and preventing resistance. He suggests that the path forward is patient selection. He points out that patients with high-risk features like brain mets or maybe co-occurring alterations like TP53 mutations might be the ones who truly need this heavy combo up front.
And his take on Optotrop?
He views sac-TMT as a very promising treatment option. He sees it as a potential new standard for that incredibly difficult-to-treat post-TKI population. But he immediately raises the next logical question, which is sequencing.
Ah, yes. The million-dollar question. If we use chemo up front as per FLAURA2, what do we do second line?
Exactly. You've already used your platinum pemetrexed with your osimertinib in the first line. You can't really use it again in the second line. So does that mean sac-TMT moves up and becomes the go-to second-line agent for everyone? Or if you save chemo, do you use it second line and save sac-TMT for third line? The optimal sequence is now a complicated puzzle with no clear answer.
And his final point was about the overall goal of therapy, wasn't it?
Yes, and I think this is so important. He says we have to move beyond just prolonging survival. The ultimate goal must be durable cures. We need to address all the hallmarks of cancer, not just the EGFR mutation, but the tumor microenvironment, the metabolic changes, the immune evasion. He's pushing us to think bigger than just one pathway at a time.
I love that. A call to action. Okay, before we get to the practical takeaways, I want to do our Teach the Fellow segment. We have two perfect opportunities here from these papers.
Let's do it.
Teach moment number 1. In Optotrop, you mentioned the term hierarchical testing for overall survival. Walk the fellow, or, me, through that.
Yeah.
Why do trialists talk about that? What does it mean?
It's a great question, and it's a really important statistical concept to protect the integrity of trial results. So in any clinical trial, you have a budget for false positives, usually set at 5%, or a p-value of 0.05. We call that alpha.
Okay.
If you test a bunch of different endpoints, PFS, OS, response rate, quality of life, each one gives you another chance to get a statistically significant result just by random luck. It's like flipping a coin enough times.
Yeah.
Eventually, you'll get 10 heads in a row just by chance.
You're increasing your risk of a fluke finding.
Exactly. Hierarchical testing is a pre-specified, strict ordering to prevent that. You have to win on the primary endpoint, in this case, PFS first, that's the gatekeeper. If and only if that is statistically significant, you're allowed to pass through the gate and spend your alpha on the next endpoint in the hierarchy, which was OS.
So if they had missed on PFS, even by a little bit,
If the p-value for PFS had been, say, 0.06, they would not have been statistically allowed to test OS for significance. Even if the OS numbers looked amazing, it would have been considered just exploratory or hypothesis generating, not a statistically proven finding. But in Optitrop, because they absolutely smashed the PFS endpoint, they unlocked the gate to test OS formally and prove that benefit too.
perfect. Okay, teach moment number 2. Let's look at FLAURA2. We saw a nearly 10-month gain in median survival, but the hazard ratio is 0.77. For a fellow in clinic, which number matters more? How do you explain the difference?
Both matter a great deal, but they tell different stories. The median survival is a single point in time. It's the day on the calendar when 50% of the patients in that group are still alive. So osimertinib chemo pushed that specific day back by 10 months. That's huge and very tangible for patients. You can tell them, on average, this may give you almost another year.
Okay, so it's a timestamp.
It's a timestamp. However, the hazard ratio, which was 0.77 here, describes the entire survival curve. It's a relative measure of risk over the whole study period. It means that at any given point in time during the trial, a patient on the combo arm had a 23% lower instantaneous risk of dying compared to a patient on the monotherapy arm.
So it's more of a continuous measure of the treatment's effect.
Exactly. The median gives you a single powerful timestamp. The hazard ratio gives you the magnitude of the treatment effect across the whole population for the whole duration. Both are critically important to understand the full picture.
Awesome. Okay, let's bring this all home. It's Monday morning. I'm in clinic. The coffee is brewing.
Let's translate this into practice.
I have a newly diagnosed patient, 62 years old, good performance status, with an EGFR exon 19 deletion. Based on FLAURA2, who should consider strategy A, the combo, versus strategy B, the monotherapy?
So for that patient who is fit, I think you have to have a discussion. But if they have high disease burden, especially if they have CNS metastases, or perhaps if they have the L858R mutation instead, I am now strongly considering recommending the combo, OC plus chemo. The data supports that for these higher-risk patients, the extra toxicity buys them significant, meaningful time.
And who are you still sticking with monotherapy for?
If the patient is frail, elderly, has a poor performance status, or simply tells you that their top priority is quality of life, specifically avoiding IVs, alopecia, nausea over maximizing survival duration, then monotherapy is still an excellent and now perhaps more tailored choice.
Right. It's about shared decision-making. Now, scenario 2. A patient I've had on osimertinib for 2 years has now clearly progressed. They're still fit.
Based on Optitrop, for that resistant patient, you should now be considering sac-TMT as your go-to second-line option. If they are fit enough for an ADC, the data is clear. It significantly beats standard platinum Pemetrexed on every important efficacy metric.
How do you phrase this to a patient, that first conversation about FLAURA2? What's the script?
I think you have to be direct. Something like, we have 2 excellent options to start with. The standard is a very effective and well-tolerated pill. Our newest option is that same pill combined with 4 months of IV chemotherapy. The data suggests this combination could add nearly a year to the average survival time, but it requires coming in for those IVs and dealing with temporary side effects like fatigue and low blood counts. Let's talk about what's most important to you.
And finally, let's do 3 quick watchouts for the clinician. What are the key takeaways to keep in mind?
Watchout number 1, stomatitis in sac-TMT. It's the main new side effect to learn how to manage. 64% of patients get it. Prophylaxis with things like magic mouthwash and early aggressive management are going to be key to keeping patients on treatment. Watchout number 2, safety in FLAURA2. 70% grade 3 or higher AEs is no joke. Don't underestimate the chemo part of the combo. These patients need close monitoring, especially during the first 4 cycles.
And number 3.
Watchout number 3, generalizability of Optitrop. Remember, this data is exclusively from an Asian population in China. While the biology of EGFR and TROP2 is likely similar, we have to await Western confirmatory data for full regulatory approval and widespread adoption in all regions. Be excited, but be patient.
The ceiling has definitely been raised for EGFR-mutated lung cancer. It's more complicated, but the outcomes are getting better. We are squarely in the era of combinations.
No doubt about it. It's an exciting and challenging time to be treating this disease.
If you found this helpful, share with a colleague, subscribe so you don't miss next week's study.